Good morning, and welcome to this plenary section dedicated to the current situation in drug addiction and especially in opioid addiction. Unfortunately, Eva Montoya is not present, and we have a little bit more time for discussion. The situation, the current situation in Europe is not certainly the better in these 10 years of time. And I think that especially in Eastern Europe, the idea to treat drug addicts inside the psychiatric setting is not the leader line of researchers and of clinicians. Today we have a big expert in the situation in Europe, the first speaker, Alexis GOOSDEEL, Executive Director of European Union Drug Agency, that is the biggest agency for the information on drug addiction in Europe. Thanks, Alexis, to be with us, and the floor is yours.
Thank you very much. Grazie mille, Icro. Bonjour. Je vais profiter que nous sommes en France pour
Hello, everybody. So, since we are in France, I'm going to use my native tongue. I would like to thank and congratulate the organizers for this 17th edition of the conference. And, well, this is a conference that is very important for many people and for myself, because it shows the trends, it shows the direction. And I would like to pay tribute to Pierre Dadier and Gouffens. And I remember the first edition of the conference. And I remember that the first time it took place in Saint-Tropez, and it was only medical doctors who had the money to afford going to Saint-Tropez. Now I'm going to give you an overview of the situation in Europe, and what I can say is that the situation, as Icro MAREMMANI was saying, has changed not only in Eastern Europe, but in the entire European Union. And today we are facing new challenges. One of them is that we have never had so many available substances, so many products that are available in the European market. We have seized, confiscated 400 tons of cocaine in 2023. Sorry, the sound was cut. And so we know that there are lots of confiscations in the different ports of Europe. And, well, we could hope that the measures undertaken would have an impact in the situation. So I have chosen to illustrate this changing situation. I've chosen the myth of Sisyphus, or at least a modern version of it. I'm going to show you that at the end of the presentation. One of the main characteristics of the market is that it is very resilient. And in this regard, it is important to underline that in the European Union, the main driver of the market is the offer. It is not the demand. There's this narrative in Europe, there's this repressive narrative in Europe, which is about fighting the users, and which is about the fact that there would be no problem with drug trafficking if there were no users. However, what we observe here is exactly the opposite. It's the pressure of offer with commercial aggressive methods. So we have never ever had this wide range of available drugs. We are the first exporters, worldwide exporters for MDMA, for ecstasy. We have also seen an increase of illegal labs that have been detected in the European Union for the production of methamphetamines and amphetamines. And these labs have industrial capacities of production. There has been links between these illicit labs and Mexican drug cartels. Then there's cross-border trade, not only of substances and drugs, but also equipment and the chemical products that are necessary to manufacture drugs, the precursors. And then there's the online platforms that also play a very important role. Because, well, sometimes it's not only the dark net, but the surface net that plays a role. You know, there are all these apps, there are all these messenger softwares, and there's the telephone as well for drug dealers who have lists of clients, and whenever they change cities, they sell their clients' list to other drug dealers. So anybody, any user can place an order, and in 10-15 minutes, he will have that order delivered. So this is the current dynamics, and these dynamics are very strong, and that's why I choose to talk about substances, because I'm not talking here about drugs that are classified as such, but rather substances. And then there is another problem that appears in the last 6 to 7 years, but it's really changing the market dynamics. And this is going to have a very important impact in policies, which is violence. First of all, because up until 10 years ago, when we were talking about drug-related violence, the European Commission was preparing a strategy, by the way, for which we have provided scientific support. Well, we were talking about violence relating this to Central America. But today we are talking about violence related to the European Union and namely in France, where there have been also some events. So today we're facing certain behaviors which are very difficult to explain, and that's why we're really researching on this. There's this ultra-violence that is perpetrated by youngsters and adolescents. We've been talking about what was going on in Marseille and a little bit everywhere in Europe. I mean, it's not only in Marseille or France, it's taking place everywhere in Europe. And of course, this will have a very important impact in coming years. And I would like to say that the danger here in terms of policies would be to accept this false dichotomy between a discourse which insists only in harm reduction without bearing in mind anything else, and on the other side, an approach to relaunch this war against users with measures that would only make vulnerability increase. And this is actually something that has been proposed in many countries. For instance, they're talking about suppressing certain social benefits for those families where parents may be users. So, well, there are changes ahead. And we saw 15 years ago the European market of stimulants bloom. And stimulant users would choose their preference product or their core product. And actually, it all depended on the availability of the product. So in the Atlantic front of the European Union and also in Italy, it was cocaine that was available. In the Netherlands and Belgium, it was rather ecstasy. And in Northern Europe, it was amphetamines or methamphetamines. And in Czechia and Slovakia, it was another methamphetamine. But this has really changed, and we have now 419 tons of cocaine that were confiscated in 2023. We also presented a report with the estimations of the latency period, because it seems that there's a latency period of 12 to 13 years between the consumption of cocaine and the first time it is requested. And there's also the fact that the precursors that are used to produce stimulants in the European Union, well, we have gone from 54 tons of precursors confiscated to 118 tons in 2023. So this was a great increase. And in 2023, we have confiscated 37 tons of catinum, synthesis catinum, which is one of the precursors for psychoactive substances. So all this market with precursors is increasing. And we're also witnessing an increase of production in Europe, an increase of environmental harm as well, arising from that production, and also the production of ecstasy and methamphetamines is increasing as well, even though for methamphetamines we have not yet observed a general increase of consumptions. So it seems that the production of amphetamines and methamphetamines is rather aimed at exports. And 12 tons of Captagon, if my memory is right. So, well, what we see is that there are certain pouches of consumption. In Catalonia, there is a niche market for the consumption of methamphetamines for people who are using chemsex. And it seems that this kind of use goes beyond chemsex. So we need to adapt prevention, but also we need to adapt the response to the situation. Now here, I'm showing a slide to really make a transition towards a novel that inspired me. The first novel was The Cult of Performance. The second one was The Uncertain Individual. And as we were saying yesterday during dinner, I think that today we are witnessing an abusive promotion of the augmented individual. Let me explain. There is a flow of offer for products, for substances of all kinds. And at the same time, individuals are more and more isolated in society. So what is becoming weaker is this social fabric that would allow to maintain and to hold all citizens together. And now, if I may repeat what one of my colleagues was saying, and he was very accurate about this topic, when we talk about this shift in prevention, there's the risk of talking about prevention as something individual, and there's the risk to neglect the community dimension. Now, for opioids, of course, this is the main conversation topic, especially because of the epidemics in the US regarding fentanyl. And in the European Union, we're talking about polyuse. So our mandate as an agency, a drug agency of the European Union, is to be an observatory and to make propositions and recommendations in terms of responses. And today, 15 out of 27 members of the European Union only have adopted our directives and the directive lines for naloxone administration. And actually, I'll be at the European Parliament in 3 weeks. It will be my last discourse at the European Parliament because the mandate ends in December this year. And I'm going to call for measures, and I'm going to call as well for anticipation, because if we have to wait for an epidemic, an opioid epidemic to happen, it will be too late if we want to change the legislation then. And I have to say as well that the thing here is that in the European Union, we have a rather balanced approach regarding drug policies. I mean, it's not perfect, and there are many things to improve. But if we compare to other regions in the world, well, there's no comparison possible. And we have to remain protected from the risks ahead. And also in Europe, there's a price to pay in terms of lost lives. I remember when we promoted the program of risk reduction in Belgium, there was this amount of people that had died of drug use and AIDS. This was something forgotten in time. And to me, the most important and maybe the most concerning issue is that it is really urgent to learn lessons from everything we did in the last 30 years. And we have to be ready for the new risks. And there are many challenges associated to cannabinoids. There are lots of products. I'm sorry, there's a sound cut. 23% as an average for resin and 11% for weed. But we see as well that there are these liquids that are used for vaping, and this represents 80% of THC concentration. There's also the difficulty to follow up and to understand well what is going on, and there are many changes as well. Our mission is to provide scientific support, but also to follow the assessment of new initiatives, especially for the regulation of cannabis consumption in countries like Germany, Luxembourg, Malta, the Czech Republic. So here, sorry, another sound cut. So why are we talking about semi-synthetic drugs? It's because they are produced from CBD. CBD is of natural or vegetable origin, but this is then transformed in semi-synthetic cannabinoid. The first molecule that was discovered was THC, and today there are 20 molecules that have been discovered thanks to the European warning system. And about this system, in December last year, we had discovered since 1987 1,000 new psychoactive substances that had never been discovered yet in the European Union market. And the last study regarding school population confirms this. Sorry, there's a sound cut. Again, studies are lacking, but the current studies show that vaping and electronic cigarette could also lead to moving to cigarettes and all the associated problems. Yesterday, we launched in our observatory, we launched the new reports of our survey for school population. Now, I'm not going to dwell on this right now, but the report is very interesting. It shows the evolution and a rather positive evolution regarding alcohol and cigarettes, a little bit less positive for cannabis. But I think that the report is interesting, and it leads to many questions that we have to ask ourselves, because we see the wastewater epidemiology, and according to this data, we see that there's an increasing consumption. So we need to see about that. And today I wanted to share with you an experience that was presented in the Health Club conference in Ghent, in Belgium, in the summer. So it's a study that was made in Flanders. It was paid by the Flemish government, and it was a pilot project that would use the services of an influencer to see how to pass video and make some exchanges with people who follow him. And there were two lessons learned. First of all, users were asking why the video was in Flemish, actually, and because Belgium is a small country, and since the program was aimed at many users, well, they were thinking that it was a little bit restrictive to be using only Flemish or Dutch. And then the other question is, why did you want to talk about cocaine only? And they said, and we said, well, it was according to our studies in epidemiology. And they answered that they were using many other substances different than cocaine. But anyway, all these exchanges allowed for a debate, and the influencer was talking about his addictive behaviors. For example, he was a workaholic and he could not manage this. So these difficulties allowed the followers to share and to talk about their own difficulties. So this became a space of exchange. So this is just to show you that there is this gap between the statistics that we can collect at the European level and reality. What we need is a local diagnosis. And that's why I see here that we may be going back to a very good method, which is research through participatory action. I think that if we want to get the right diagnosis of a problem and to have an adapted response and to understand what the substances are, we need to ask the users. We need to really ask all the actors. And in this case, for example, for the substance that was aimed made us neglect many other possibilities. Now, I'm not going to make a detailed list of vulnerabilities, because I think that it's not only about vulnerabilities, and social media are talking about all the bad news only, but we need to remember that there are many positive things going on. We have resources. One of the main problems that we have everywhere in the world, and here I always invite people in Europe not to look at what's happening in the US, is polarization, because, well, this is the tree that hides the forest. Polarization, the lack of respect, the lack of credibility for scientific knowledge. I mean, in Europe, there's nothing to envy regarding other regions in the world, and our intervention is to promote our work. And actually, this polarization could be a risk. I think that there's this risk as well to have an eruption of violence in the European Union drug market. There's this risk to come back towards more repressive activities and more repressive practices. There are countries that, and politicians who are talking about drug and drug addicts. And what we have been doing in the European Union in the last 30 years was based upon human rights and fundamental values that are enshrined in European treaties and that have to be applied as well for drug users. And another problem that we were facing is the SPAT study that we published yesterday, and the SPAT study insists in these recommendations. There's this problem with mental health amongst young people, even before the COVID pandemic. And there's also the impact of the war in Ukraine, and also for other countries, for neighboring countries. There's this feeling of insecurity for many Europeans, and also the situation in Gaza. All this has consequences in countries that have Jewish and Muslim populations. And actually, if we do not pay attention to all of this, we could be facing problems. There's this double discourse that we sometimes use in the European Union with our partners outside. And actually, there's this impact in mental health for the population in general, but especially for young people. And the consequence, as the SPAT study was showing, is that there's this strong movement. I mean, there's an improvement of the situation for cigarette, alcohol, and even cannabis consumption, but there are other addictive behaviors that are developing. And now to finish, I'm going to show you the last image. I mean, you will have all of this later on. Yeah, just a final point. I think that the most important thing is to push for a holistic policy and not a hostile one. And I would like to come back to Sisyphus, because I'm reaching the end of my mandate, and I participated in the creation of the agency since the very beginning. And now that I'm coming to an end of my mandate, I would like to pay tribute to all the Sisyphus of modern times. And I would like to come back to the confusion of Albert Camus talking about Sisyphus. He said, I'm going to leave Sisyphus at the bottom of the mountain. The struggle to the top is enough, but we have to imagine that Sisyphus is happy, and we have to imagine that all of our clients are happy, because most of the time you are the last link that separates us from the top. And you will always be welcomed by the person who is lacking confidence, but you are the first, you are at the forefront, and you will always have this smile and this motivation. So for me, after 30 and 40 years of mandate of this career, I would like to thank you all for your support and encouragement. Thank you very much.
Thank you very much for this presentation. Now we are going to pursue with the second presentation. We will optimize the time, the available time before break. We greet and welcome Professor of Minneapolis, Professor at Minnesota, Gavin Bart, Director of Addictions and also Public Health. Yeah, you will present an electronic health record integrated clinical decision support tool to improve opioid use disorder screening, diagnosis, and treatment in primary care, a randomized trial. Thank you.
Thank you so much. I'm very happy to be here today, and I know we're all disappointed that Yvonne Montoya could not be here, and I want to thank all of the federal employees in the United States during the shutdown, many of whom continue to work without pay. So my thoughts are with Yvonne. I'm going to be changing the pace today and talking about how to increase the uptake of addiction treatment within general medical settings. recognizing that at least in the United States and in many parts of the world, there will never be enough addiction specialists to handle the scope of the problem. So I will be highlighting results from a NIDA-funded study where we attempted to use an electronic health record clinical decision support tool to support primary care providers in addressing opioid use disorder. Doing this took a large team, so I want to recognize my very large team working on this and the NIDA Clinical Trials Network. I have no financial disclosures other than my grants from NIDA to report for this. For many years in the United States, we've been trying to have more general physicians prescribe medications for opioid use disorder, but progress has been challenging. And it's not so much purely stigma, and it's not even a lack of knowledge. What many providers, doctors, nurses, health administrators are telling us is that their health system has too many barriers that get in the way of them being able to prescribe these medications. They don't have enough time, they don't have enough support in terms of staff or workflow. So we wondered if there could be an electronic solution to helping these clinics. But more than just translating a guideline into a smartphone app that still requires a doctor to go back and forth between the app and the electronic health record and the patient. We wanted to have something that could be integrated into the electronic health record that would be adaptive to the individual patient. In other words, it could and provide recommendations about that specific patient to the doctor, rather than general recommendations that may not apply to the specific individual they're seeing. To do this, we created a clinical algorithm. It was over 25 pages of decision trees, as this image on the left will show just one page of them. This could be seen as really hard to do and too complex. What the image on the right is a decision tree. If any of you use Waze or Google Maps to find directions, what is on the right is a decision of crossing one intersection in a street. So we wanted to create an equally real-time support tool for providers while they're seeing the patient. It's directly integrated into the electronic health record. This is what the doctor sees. It has many different tabs on it. The one that's highlighted on the bottom is diagnosis, to help diagnose and screen opioid use disorder. If the patient is already coming to them with a known opioid use disorder, they can simply skip that tab and go directly to selecting a medication. And it walks them through the process of choosing buprenorphine or referring someone for methadone or using naltrexone. You'll see the green button on and below it, they can automatically click a button to refer a patient to a specialist if they, as a primary care provider, do not want to manage this patient's opioid use disorder. As I said, it's individualized to the patient. So there's some writing here about the patient they're seeing. For example, this one, the patient has signs of depression. And so the provider will need to take that into account when they're addressing their opioid use disorder. Under another tab, when it has options to select medications, you'll see, for example, the electronic health record indicated or knew that this patient had severe liver disease. And so it automatically eliminated options of naltrexone for this patient. And this healthcare system chose, in cases of severe liver disease, they wanted the addiction managed by a specialist, not by primary care. The radio buttons on the left allow the doctor to click on them if new information is obtained. Maybe they didn't know the patient had liver disease. They could then click on it, and the types of decisions they would make would be curated based on the characteristics they selected for the patient. This was a clinic that had options to start buprenorphine in the clinic or send the patient home. And there were different printouts or algorithms to help the doctor do either one. So this gives you a sense of what the tool looks like. We put it to trial. We did a randomized trial of 92 primary care clinics across 3 different healthcare systems spanning about 5 states within the United States. Half of the clinics, the doctors had access to this tool, and half of the clinics, the tool was running in the background, but the doctors could never see it. And by having it run in the background, we knew every patient they saw and every decision they made. So we knew if they were diagnosing opioid use disorder, we knew if they were ordering naloxone, we knew if they were referring, but they had no access to a tool to help them do those things. The aims of the study, we had multiple primary aims. We wanted to see if access to the tool would increase clinics' ability to diagnose opioid use disorder within 30 days of the initial visit, whether it would increase prescriptions for naloxone, increase medications for opioid use disorder, either directly in primary care or through referral, and the percent days covered by a medication in the 90 days following the first clinic visit. There are also some mixed method approaches. There were 10,000 patients who were considered high risk for opioid use disorder during the course of the study, evenly split between the control clinics and the intervention clinics. You can see the characteristics. About half were female, slightly older in age, which is representative of primary care in the United States, mostly white, and not primarily on public assistance for their medical care. There were a number of comorbid disorders in terms of anxiety, depression, bipolar, and a number of people already had a diagnosis of an opioid use disorder, and only 2% had a recent opioid overdose. So this was a large sample size. So what were the results of letting doctors have access to this tool for anywhere from 6 to 12 months of time while they're seeing patients? Well, unfortunately, the tool did not increase the diagnosis of opioid use disorder, but it did increase significantly the order of naloxone rescue kits. And it increased either the initiation of medication for opioid use disorder or referral for initiation. So 2 important and significant findings, but there was no difference between the intervention and control clinics about the percentage of days covered by a medication over the 90 days following the initial visit. And let's do a little reality check. While the results were significant, the numbers were a little disappointing. Already, there were 7% of people at baseline in usual care clinics on buprenorphine and 11% in the intervention clinics. And at 30 days, the numbers did go up more in the intervention clinics than in the control clinics. But ultimately, those increases were very modest, only small percentage points. The majority of people still were not given medications for an opioid use disorder, even though they warranted it. So we made progress, but not as much as we would have liked. There were some important benefits to subpopulations. So the small percentage of patients who were Black were more likely to get a prescription for a medication for opioid use disorder, as were those who identified as American Indian. And interestingly, those who were identified as being at a moderate risk for opioid use disorder compared to those who are high risk also were more likely to get a medication. I think the tool helped identify those who were at moderate risk, were those who were already at high risk. It was obvious they had a problem, and so a tool wasn't necessary. But maybe those who were less likely to be identified, it was helpful. Did it impact the overall cost of care? Well, healthcare costs in the United States goes up every year. So this is more a matter of, did the cost go up less in the intervention clinics than in the control clinics? And the overall expense per patient identified with an opioid use disorder was $1,000 less than the amount it went up in the control clinics. Now, if there were 5,000 patients, a little more than 5,000 patients in the intervention clinics, that works out to between $5 and $6 million per year. So there can be important cost savings. So to conclude, we did a cluster randomized trial of 92 clinics for a clinical decision support tool to support primary care providers in addressing opioid use disorder. We were able to see increases in naloxone prescriptions and in initiation or referral for initiation for medications for opioid use disorder. What will we do next? Well, we're talking about providing more implementation support. The tool seems to work, but it was underutilized. So can we support clinics in using a tool that can be helpful to them? We're also talking about using artificial intelligence to help augment some of the decisions and the supports available to primary care providers. And I look forward to perhaps presenting results of future studies here in Biarritz. So I want to thank you, and I'm happy to take questions now or after the session.
Merci beaucoup pour cette deuxième présentation, très complémentaire de la
Thank you
première.
very much for this presentation, which completes very well the first one. Are there questions amongst our audience? Otherwise, yeah, now we can see that finally it is a tool which is helpful. It is very important because initial training of health professionals is clearly not sufficient. It doesn't allow to seize all, to take into account these medications and treatments. The use is not that important. The question is whether the way the application, the app works, the characterization of the problem. How could you identify that something could be identified in the initiation linked to the opioids? Sometimes there is an optimization to be done, and of course the treatment has to be set and adapted. So 3 different stages. What could you identify as for your application?
I hope I was able to catch all of your response.
I can repeat it in English if the translation is not enough.
I'll give an answer, and if I didn't quite catch it, what I was not able to go into because of the time constraints is we as doctors see a lot of patients. And if you're a general doctor, the majority of them don't have opioid use disorder. It is too hard to ask every single patient about opioid use disorder. So one of the things integrated in this tool is a risk calculator that potentially identifies those who are at risk. It has a positive predictive value of about 10%, which is consistent with other screening tools, maybe a mammography for breast cancer, immune testing, fecal immune testing for colon cancer. Positive results have about a 10% positive predictive value. So this tool can flag, rather than flagging every single patient, flags patients who are identified as being at probable risk for having an opioid use disorder. And that then cues the doctor to go in and begin using this tool. They aren't being forced to use the tool. And when we did interviews with the doctors about the tool at the end, ultimately they said they were so busy, their practice is too busy, that even when a tool is available to be helpful to them, they don't have time to use it. And so that's why we're wanting to think about the next step of providing some additional support.
Merci effectivement pour cette réponse. Ce qui est très intéressant, c'est que la population que vous
Thank you
aviez
very
dans-
much for your answer. In the populations in your study, do they correspond to the general investigation with toxic fatalities, with the predominance of women at a higher age than product consumers or drug users? So is it representative of what we see in primary care? And well, this is very interesting indeed. Une coupure, there's a cut in the sound from on the interpreter sound.
With a difference from north to south, but it's similar. There is some project in the agency to make a survey about treatment, because the treatment is very different in all parts of Europe, and the methodology is different, and results are different.
Thank you. Oui, thank you. That's a fantastic question, because that's the part I've cut in my presentation. Donc, je remercie parce que c'est le
I'd like to thank you because that's what I cut out from my presentation to be in time. What I wanted to add about the treatment, there's a cut in the sound, apologies, we do not hear the speaker any longer. So the risks and agonist treatments, we have prioritized and put the emphasis on substitutional treatments and reduction of risks. And thus, sometimes in certain conferences or meetings, I feel that it's almost mandatory to talk only about this risk reduction or repression. I'm showing Gavin, but nothing to do with you. But where I feel that this debate or discussion is not set in the right place is that we had a meeting of strategic programming last week in Lisbon for the program of the next 3 years, and I invited my successor, the future director of the agency, who were to come into position, Lorraine Nolan, next January, I believe. A cut in the sound again, apologies. For the 5 next year, I think it is urgent to invest in the treatment. It is not obscene to talk about a cure or treatment, and in some discussions, it's almost not well seen to talk about a treatment. I think that the risk reduction is crucial and needs to be reinvented. I also think that we need to include, and this is why I talked about a local diagnosis. For me, the future of risk reduction is on the local level, where there are violence issues and violence needs to be embedded in the analysis. This risk reduction, it's not only for harm, it's for everyone, not for the users. If we want to build sustainable questions that are supported by the users and the populations, we need to enrich the analysis. At least we need to build new responses for the risk reduction when it comes to the new risky conducts or behaviors. Our report sees that there's a latency period of 10 to 13 years between the initiation of cocaine and the first treatment demand. Possibly for consumption of crack, it's a shorter period, but accessibility of consumers or users is not easier. I'd like to say, if we count 10 to 12 years and we imagine that the increase of the availability of cocaine on the market, which pushed consumption and appeared about 7 years ago, this call for the Parliament that I'm going to launch in 10 days is that we have indirect data. The epidemiologies of wastewaters indicates there is a huge consumption of cocaine and stimulants. And today, since the new mandate of the agency is EU preparedness for drugs, the preparedness on drugs, whether for the short term or long term, means that there is a question. For me, the answer is clear. We are not ready if there's a new epidemic in opioids, because with 15 countries out of 15 who have the right, have taken dispositions to face this, others have done nothing, so that they are worried or concerned at all the international meetings of what is happening in the USA, but it's important for them to take action in their own countries. And secondly, we must move forward and promote a massive investment in research and in service offers, because once we will have a new wave of treatment demands for dependency to cocaine or stimulants, I believe that in your centers, treatment centers, we don't have the right resource to welcome a new increase. And in the same way, for opiates and generalist doctors are not equipped in the right way. And I think that Dominique said it. He's been working for 35 years in the training of these doctors. It would be interesting for him to say what he thinks about cocaine. We're not ready, but in terms of protocol, I read a review a few months ago on the way in which the craving was taken into consideration in the treatment protocols to dependency to cocaine. The craving in none of the studies was in the primary criteria, whereas we know that the craving is the cause number one for a relapse. I believe, and this is why I want to launch this call at the Parliament, the European Parliament and the Commission decide on the priorities for research. So my call for action will have an impact, a financial concrete impact, only at the beginning of 2027, because the programming of these research program takes a certain time. And I believe if we want to be ready in 2-3 years to face the increase of demand, we must increase the knowledge. And it's time to rehabilitate our treatment. It's paradoxical that we need to say this today in Europe, whereas today we are in Biarritz and the room is full of medico-social people, specialists, and there's a gap when it comes to the knowledge of what does exist. And this is one of the main priorities for me, number one priority for the European Agency of Drug. And my successor shares this diagnosis. Thank you. Do we have other questions in the room? Any reactions, comments? So I'd like to take advantage then to... Indeed, the answer is not a single answer, it's a multiple answer at different levels. We see that the drug market uses all the codes, the marketing, commercial codes that exist for all other products, with indeed a strength for the production and dissemination, solicitation of users. exactly as what we have for all the other markets. This contributes, of course, to make it mundane, all the products. We see that some are like psychostimulants or ketamine or cannabinoids comparatively to opioids that have a different image. But we see that this society has evolved, and we see that the offer of products has evolved and has set or is duplicating the codes of young people. We see today that it's important to finally have multiple actions at different level, of course, when it comes to criminality or crime, but how are the products addressed to the population and young people, and how can we help them get ready to face this in this modern society? There's the whole issue of the fragmentation of the society, the social support, and theories of Alex that show that this society is fragile. And we talked about augmented or increased, that all of these is due to these drugs. So very quickly, some people lack references and ability to see how it works and to use all of the psychosocial skills that are insufficiently integrated as soon as possible in the pathways of these young people, because we see that we are always one train late with the offer compared to the offer that is growing immensely. There are new products all the time, and knowing that there's no longer a difficulty in European coordination. We see that there are actions that try to coordinate things. We see there are differences between countries. What is your point of view, your vision, and how could we improve it all? How could we impulse things or bring an answer? As you said, a more holistic one, a more global answer, faced with a problem that cannot be resolved with just a unique repressive strategy.
J'ai une ou deux idées à partager avec vous encore, et puis je pense qu'on est arrivé à l'heure. Pour moi, une des questions, c'est, je pense, et c'est l'image que j'ai prise en mai, nous avions le dialogue entre l'Union européenne
The
et les
picture
pays.
I took, we had a dialogue between the EU and the Caribbean countries. We need to acknowledge that we have a problem of human development. I think the fragmentation of politics and actions and fundings, I can't detail all this splitting of the political narratives, but in our postmodern and post-truth society, the trouble is that we have no one presenting a project of society. So for French people, France, well, it is the joke about the cancer of the right arm. We have services, care services for the cancer of the right arms, but not for the left ones. Well, and today, more and more, we are facing a context in Le Monde. They talk about the multi-annual budget of the EU and negotiations, but we know that we have to reimburse 800,000 billion, 800 billion dollars that we need to invest in the industry defense industry to pay off well the delays, the things we didn't do before. Before we had money, and now we don't have that money anymore. So a huge challenge, as you can imagine. One of the things that when I started in my mandate was of transforming the agency, improving its public value, as we say in the States. My priority was to make this agency more useful. There are plenty of things that can be done to call for attention so we can have interesting responses at a local level. When I pay tribute to all the attendees and in the EU in the sector. We have many more resources than we can believe. We need to make it known. Last year, we organized the first European conference on violence linked to drugs. I insisted to have this conference, but I even insisted more, so it would not be a conference on the law enforcement. I insisted on the support to our communities. So I think we are in a hard environment, and as I said with Bertrand Lebeau just before the opening session this morning, I think it is not surprising that many people feel anxiety or stress because news in loop only augment, only increase our anxiety. But I think that what I've tried to do, what we try to do with the agency the last 10 years is taking risks also. I mean, taking the risk of taking the floor without leaving our role, but without criticizing the declaration, the statement of one minister or another. There is always a way to say yes, but not this way, as we would say in psychoanalysis or psychiatry. Thank you for this answer. No reactions in our audience. Yes, there is one. Yes, thank you. I would like you to comment on what you said, whether it was the chicken or the egg. What is before, the offer or demand? Against the idea according to which demand would be first, you say that this idea allows to accuse. Sorry, it's a pity because we lost here the sound. It will come back, fortunately. I think it is possible to say that demand, if it's not first, it is extremely important within a very powerful dialectic with offer. And we do not accuse for that the users as we do in France, accusing them to be at the origin, at the source of the problem. Are you sure that the only argument in favor of preeminent of offer is linked to the use that can be done of the primauté of demand? Well, you will have to write on this in your next books or essays. You are totally right. Sorry, another sound interruption. There might be some dichotomy between protecting the use and whilst others want to defend use absolutely as if it was the only one value. And those who, on the other hand, pretend to defend citizens and want to put this to slide through this political agenda. The question is not that simple, but what I remember from your question, because it is a very interesting one, it is the fact that on one hand, what is still unacceptable, I don't like these ideas of punishing vulnerable families, withdrawing assignments or fund allocations. Sorry, another sound interruption. I was born a bit before this petit bourgeois. That is to say that in good families, between inverted commas, there are no problems. We used to listen to these speeches. In good families, if you were well grown, there would be no troubles, but we know that it's far from truth. So I am absolutely against this narrative. On the other side, We take Marseille and Brussels when we talk about violence. In Brussels, with an exponential curve of violent episodes, we have to raise the question about responsibility of users, not in a punitive meaning, because in some countries we discuss, well, some are proposing to modify the law again of protection of youth and protection of minors. So the age at which they would be accountable would diminish. But this is not the answer. I'm not talking about the absence of the role of prisons in the reinsertion. We need means for police. We also need a means for treatment or risk reduction. But if all these people were not in Brussels downtown to get a supply and come back home, there would be less problems for the control of territory by the gangs. Consumers are part of the system, but they are not the only target in the synergetic meaning of the term. This is unacceptable. And to me, it means that the concept of prevention itself, as Gregor Burkhardt said, in the Société Européenne de Recherche, they insist on the fact that prevention, unlike what some might think, is not an individual choice. It is something which is part of the Olive 40 years ago. It is still actual. There is a context, but the context is not the sole problem of an individual. What are the new intervention means to address use to include this problem in local diagnosis? I think that we need to reflect on this, but I do not have the answer. But we need to raise the question. We cannot leave consumption outside the diagnosis of the problem, I think. Thank you for this response. One question, Jean-Michel Delille.
Merci. Deux questions, si c'est possible, mais très courtes. La première, c'est pour Alexis.
So a very short question. The first is for Alexis. Thank you for the presentation. You mentioned previously the contrast that exists between the improvement of indicators in youth and, on the other hand, the possible increase of levels of consumption as appeared in wastewater analysis. And who are these users? That is the question for me. We could imagine they are adults who were young 10, 15 years ago. But I'd like you to take a look at this. And a question for Gavin Bart. 30 years ago, I was in Minneapolis at the service of Joseph Westermeyer in anthropology. It was fascinating, and I heard that in the tool there was data on anxiety disorders and depression. Has there been an impact on the use of the tool, maybe in screening or a possibility of support that can, because that is key for the treatment of these addictions?
Certainly miss Dr. Westermeyer. He had many things to contribute to our field. We're still doing sub-analyses to see if there are differential outcomes in those who had anxiety or depression. These health systems already have screening processes in place for depression and anxiety within primary care. So we were not inventing it for them. They were already doing it, but we were using the information to inform the opioid process because it may impact their decision whether to refer to a specialist, whether to treat in-house. But I look forward to seeing if there are differential results or maybe better care pathways provided to those who were identified as having anxiety and depression. Well, also, since this is ATHS, we also will be getting information about testing for and treatment of viral hepatitis and HIV, because the tool is prompting that, but we did not have those sub-analyses in time for this conference, so maybe another year.
Merci pour ta question. En fait, elle me fait
Thank you very
penser-
much for your question. And if you want to, maybe a publicity for Lotto, the Tombola winners, a lot of winners. There was a funny ad that started by the winners, a lot of winners. Who are they? What do they do? And I am asking the same question for results to investigations on general populations or epidemiology of wastewater. I think that the way to tackle this, there are sources of information potentially existing and others that we can rebuild or redevelop. The existing sources are, for example, when there is a room, a consumption with a supervision, supervisors. In Switzerland, we have this, but I think there are 2 of these in France as well, and there are about 100 in the EU. So these supervised consumption rooms in countries such as Austria, where there's a drug checking program in Vienna, or energy control in Barcelona, these are people who help to give you information, day-to-day information about the people's consumption in certain group. This is a unique source. We also have a program to which some of the French cities are taking part on the level of the agency about the analysis of hair and syringe residuals. So there's a number of things that do exist, and we are currently redeveloping or resizing some of them. And the Euroden network for the emergency rooms that collaborate once again. So they work together, because by crossing the indicators that are partial, this helps to have a better idea of the situation. And another project we have developed for a few years, which is the web survey, an online survey that aims at exclusively, people who declare consuming illicit drugs or illicit. And the last campaign, we received 130,000 consumers, declared consumers, who took part in this survey in all of Europe. Maybe it's not a representative sample for the behavior of all the population, but this is how we discovered that among consumers, declared consumers or users for EU, there's an average of 10 to 12% of these people who declare using ketamine regularly. It's interesting because even if it's not a representative sample, it is a unique source of information in order to understand the size of the problem for those using. And for me, it's a bit like the question of managing risks in medicine. From my experience, when I worked at the university hospital, I thought that this occurred often. Some doctors minimize risk, and in surgery, in medicine, there's always a risk. And sometimes we're told that for the one who faces the problem, it's not 1 out of 10,000, but it's 100%. Same, using different sources. And to close, this is why I talked about participative survey and also focus groups, because we have financed a pilot project at the festival Tomorrowland, the greatest electronic music festival in Europe, with 400,000 people who gather during 2 days near Antwerp. And it's electronic music, and I went to the festival during the summer, and there were 2 fatalities by overdose, 2 only, would I say. But in fact, the user profile is completely different from the usual one in the region. To know, the 2 people were aged 31, 32 years old. I didn't get the results, the full results of the analysis, but what we knew at the time of the festival is that it was a mix of NDMA, strong high doses pills were seized, and there were 275 milligrams of NDMA. To give you a comparison, in 2000, we launched the first pan-European alert on MDMA with an elephant drawing on it. In Vienna, they found pills that had 360 grams. So in Tomorrowland, it was a mix of cocaine and MDMA with a high dosage. So the pilot project aimed at interviewing on the field, in the field, outside of the presence of the police, obviously, without the police, so people who were ready to talk about their consumption. I think that what is missing most greatly is more qualitative research. There is a kind, well, as a director of the drug agency, I'm in a good position to say that we have a number of statistics, but we forget that statistics talk about how much, but not the why or the how. And on top of it, I remember I regularly mention that the statistics teacher at the university reminded us that in best case, you need to confirm that your assumption is not a false one. And without any assumption or hypothesis to start with, I think it's also what means that sometimes we really must take our statistics into consideration and then add on with qualitative analysis from the field. It's one of the benefits of having 30 years of risk reduction in Europe, because we are in a better position than we were 30 years ago to listen to users, and this would be one of the progress we shouldn't lose. Thank you very much. We see the richness of the debates. We are going to conclude this first part of the morning with a break until 10:40. Since then, we will have 3 presentations if you want to stay on time, and close at 12 sharp. Thank you very much, and please come back on time. Thank you, everyone, for the quality of the presentations and for the assistance. Thank you for being present today. Thank you very much.